And also, it's just not good for the water system. It's not good.
Correct.
There's
Sure.
even evidence that it's getting into our fish. So let's take care of Idaho.
Yes. What haven't I asked that you think needs to get out there while we're talking on this Facebook forum?
I think the hard part here is that we're vulnerable as a community if we don't talk about it. So I think we've gotten to the heart of that. Getting people to treatment, though, we did hear that, a part of the story. There are medication-assisted treatments. There are also therapies where you don't use medication. So I think the one thing that we haven't really talked enough about is conversing about their effective treatments. And it's important for each of us to have empathy for a family member, a friend, ask the question, start the conversation, and help them, if at all possible, get to an effective treatment. This is a complex problem.
Yes.
And the complexity, of course, then requires multiple different approaches. What works for one person may not work for another.
We have to have a bit of grace, don't we, Kathy?
Definitely.
When you saw that person in the hospital doing your rounds, going back to the beginning of our conversation, today you're looking at that person. With your background, how do you see them?
You know, it's unfortunate, and they need help. Just like, you know, Cassidy was telling us that some of that's, you know, maybe the first point that they've been able to get help. We see this, unfortunately, almost on a daily basis. And a lot of times it's taking the time, you know, that your life is worth it, right? And we can help you get through this. And, you know, there's a lot of avenues for that help. Right. But I really think it's being open to it. You know, I talk to friends, and, you know, we talk through our student group at Idaho State College of Pharmacy, Generation RX. We do a lot of outreach education. And parents my kid would never do that. Yeah. And I really think everybody needs to be aware that this happens, because it can happen to anybody. You know, I mean, I have children, and you're right, it does. And I think the more that we're aware of it, knowledge, and remove that stigma that it's, oh no, that wouldn't happen to me, it's only them. Right. That is absolutely not true. It's all through our communities.
And then finally, it's teamwork. We heard that this morning too in that story. You need your team, just like you work as a pharmacist with doctors and people in the hospital, to have your team, have someone that knows your medication, a therapist, a family member, and put your team together. That's successful too.
Let's take some comments from Facebook. Karen, I know that you're monitoring that for us. What were people talking about?
Well, people are, you know, talking about the differences between the prescription pills and street drugs, and one individual kind of implying that overdoses have to do mainly with street drugs, which I know in our stories that we've seen, not always the case. I'll ask you guys to talk on that. And then also, as we mentioned briefly, a lot of people start heading down this path because of a doctor's prescription, because of a surgery, because of something they were prescribed. So as somebody who's watching today, if they're getting that very first prescription of an opioid, what are the questions that they should be talking to their doctor about, with the pharmacy and their family, to make sure they don't end up going down that path?
Yeah, I think that's a great question of, like I kind of said before, to be empowered as a patient. Ask the question, if your provider, you know, talks about giving you an opioid, ask, well, do I have a non-opioid, you know, alternative that I could take? How long are you prescribing this for me? Do I have to get to it? You know, how long do I think I might need this? You know, let them know if there's addiction that runs in your family. Ask about addiction. Can I become addicted to this medication? I really think the more that you know as a patient, customer, it empowers you to take control of that and try to minimize your risk of, you know, taking opioids when maybe something else would work, you know.
And to the first part, having to do with street drugs, it's really, as we mentioned, difficult because you don't know what you're getting. And so I can understand someone saying, gosh, that's where the overdoses come from. But the research says it's a mixed bag, that there's as many stories about how you ended up in the bathtub as there are people. And so the hard part then is to, do we care? Oh, sure we care, because we want to look at this problem from all points of view. So if we can cut down the prescriptions, if we can do something about the heroin, if we can follow the tracks of fentanyl coming from China or whatever we need to do. And I think the federal government now is putting a bunch of money into looking at each of these aspects. That's how we'll get there.
Yeah, it is a multifaceted problem, as we've mentioned. We appreciate you two being on the front lines of this, being so willing to talk so openly. And I know if people have questions that they could definitely contact either one of you, and you would be willing to talk with them too. Talk about two professionals in the medical community who are on top of this problem. Thank you both for being here. Appreciate you.
Thank you.
Karen?
Alrighty, well, we are joined now by our next round of guests, some experts in our community here in the Treasure Valley that are working every day to be a part of the solution. So we have Jeanette Day with Ada County Drug Court System. We have Dottie Owens, the Ada County Coroner, and Rosie Andueza, who works with the Idaho Department of Health and Welfare. And all three of you working every day to be a part of this solution, and the agencies that you represent and you work with are very aware that this is a problem worse in other states, but we're trying to get ahead of the problem here in Idaho so that we don't end up like Ohio and some of the other states along the East Coast. So as they're talking about the overdoses and the deaths that we are seeing, I'll go ahead and start off with you, Dottie, because this is something that not only do you see in your day-to-day job, because there are overdoses in our community that wind up at your office, but this is something that you've also kind of taken on as a personal project to be a part of the solution. So where do we stand in Ada County right now when it comes to opioid overdoses, and what kind of trends have you seen over the last few months and years?
So this year's been pretty busy for us. With our overdoses, we actually have 123 that are opioid related in one way or another. That doesn't mean necessarily that it was an overdose. We do have 95 overdoses on the year, and 65 of those are opioid only. So a little bit of misconception with that is the rest of those are combinations. So we can have an opioid with methamphetamine or methadone and some other form of opioid. So we have to take caution. And we're actually talking about true numbers just for the sheer fact that there's so many different variations with it. Our numbers are up from last year. As we've consistently seen over the last few years, which is why it's become something that's very passionate to myself in my office. You know, honestly, we got tired of the knocking on the door and having to do those death notifications on these deaths that are just so unnecessary.
And when we talk about the people that are brought into your office, unfortunately, when it is too late, who are they and how old are they and what communities are they coming from? It's not just one specific area of our community, right?
No, the majority of our drug overdose victims are male in their 40s. 66% are actually white male, middle class. The remainder of that is white female for the majority. And they're 40 to 52 years old in the age range. So most of them are middle class wage earners.
And when we've spoken in the past about this, you've kind of talked about how the kind of mentality of the office is no longer surprised to see these overdoses, unfortunately, and you sometimes are dealing with more than one at a time, or you'll have a weekend where you have multiple deadly overdoses. How does it change the day-to-day operation?
It actually is. It's something that shock value is gone. Has been for several years. And so we're just to the point where it's almost as common to us internally as bringing in someone that died of natural causes. It's the same thing with our suicide rates. And so on a whole, it's affected the office in that way, where there's no shock value left to any of these types of cases. It's very common for us to have overdoses.
And this is something that you've described as kind of your weekend project, that this is something that even when you're off the clock, you're working on, you know, kind of collecting data and learning more about what this epidemic means for our area, and what are you finding, or what are you still hoping to get answers to?
It actually is my weekend part-time job. I'm going through these cases every single night, combing through them. I want to know what the commonalities are, what we're seeing, if it's someone who got addicted because they had some type of surgery, if it's an overprescribing, what are we finding? And what I'm hoping we can do is that we can use those efforts for preventative. We can correspond with all of our agencies in health and welfare and let them know, you know, this is what we're seeing internally. These are our commonalities. They're not street drugs. They're drugs that are purchased for some kind of medical ailment, and that's the majority of what we're seeing internally. So whether it's education on how they should be taking them, overprescribing we've seen a reduction in. We pull a board of pharmacy on every case that comes through the office. I'm not seeing huge excessive medications being prescribed, 500, 600 at a time. We're not seeing that anymore. But what we are seeing is we're still not, the education piece still isn't there. I don't know why, with everything that we're saying, why are we still seeing these numbers?
And maybe this is a good time to bring in Rosie Andueza with Idaho Department of Health and Welfare, because the education and the preventative aspects is a big part of some of what you guys are trying to do with some recent grants that the state has received to distribute all across different areas. And it seems like no matter how much money you get, you could always use more. But tell us what the state is seeing right now as far as grant money coming in from the federal government. What are we using in the state here, and how are we trying to get ahead of this issue?
Sure, thanks, Karen. Yeah, the federal government has made money available to states to combat this epidemic. Right now, last year we received $2 million specifically for the opioid epidemic. We are in the second year of that grant, and now they've just upped the ante, and we are getting now $4 million in addition to that per year. So moving forward, I think they'll combine all the buckets, and we'll end up with $6 million a year going forward.
And the majority of the funding for this new grant is going to the treatment side of things, and that's something that a lot of people, the taxpayers listening at home, you know, well, why am I paying for their treatment and covering the cost for their drugs? Tell me why that's such an important part of the solution here.
I can't say it loudly enough. Addiction is a disease. And if we were talking about any other kind of epidemic, we wouldn't have those same kinds of questions from the taxpayer. People are dying every day in this state and across the country, and the federal government has made it very clear the purpose of this funding is to reduce death first and foremost. In Idaho, until now, and currently we still don't have Medicaid expansion, so we've been using our funds primarily for treatment. Of the $4 million that we just received, we're putting 75% directly into treatment. That includes psychosocial rehabilitation in addition to medication-assisted treatment, which we are finding is critical to this opioid epidemic.
And that's one of the aspects that makes this a little more expensive to cover than some other types of addiction, like meth addiction or alcohol addiction, because you have to then fund the cost of the drug for the treatment. But why is that drug, when it comes to opioid addiction, and we'll talk more about this in our next segment on treatment, but why is that needed here?
Yeah, and I know your next guest is Jason, and he knows a lot more about this than I do. My understanding is with opioids and the changes that they make to the physically to your body, it's a little bit different than other substances. A lot of people fail at recovery from opioids because the withdrawal symptoms are just too tough to get through. They can't handle it. And while the withdrawal from opiates will not kill somebody, they feel like they're gonna die, and so frequently they go back out and use. And a lot of times after they've been clean for a day or two, 3 or 4, their resistance has gone down, and sometimes that next use could be the deadly one. So by adding the medication to the treatment program, those medications remove those, or highly reduce, I guess, those withdrawal symptoms, and they help people actually get to a physical point where they can even start the long process of recovery.
And I know the Department of Health and Welfare has also been involved with trying to kind of lower the number of prescriptions that are even put out into our communities, and we're using more of kind of an online database where prescribers, doctors, pharmacies can all be logging on, and we've seen a lot more kind of, what is the word I'm looking for? A lot more people are using it, and it's being more widely used more commonly now. Why is that so important, and what have you guys been seeing at the department when it comes to the database? So
you're talking about the prescription drug monitoring program, and that is something that the Board of Pharmacy is responsible for. We have worked with them in terms of augmenting and enhancing the data that comes out of that. What that system does is it allows for a prescriber to go in and check before they prescribe to somebody. When people get addicted, they'll do anything to get you know, those withdrawal symptoms, like I said, are so bad, and so they will do anything to not have those. And sometimes that means moving on to illicit street drugs, but still while in doing the pills, doctor shopping, one doctor to the next, to the next, to the next. So we can stop a lot of that behavior if prescribers are looking at the PDMP before they prescribe. Pharmacists are also looking at that. And what we did with some of our money early on was work to provide what are called prescriber reports, so that prescribers will actually get a report that shows their prescribing practices compared to other prescribers of the like type. So an oncologist versus an oncologist, a pediatrician versus a pediatrician, so that they're getting feedback on, gee, am I prescribing more than other people in my field? And we're really working to try to educate more on lowering those prescription rates. And our division of health within our department is also doing a lot of prescriber education out there.
And have you seen other prescribers and doctors starting to lean towards more alternatives rather than starting out with an opioid prescription? Are you seeing that kind of trend moving away from it?
I'm hearing that anecdotally. Now, I don't have any data to support that, but I am hearing that anecdotally. I'm also seeing some changes anecdotally, again, within the insurance agents companies, where alternative medications and our physical therapy, for example, are being promoted and easily accessible. You know, you don't need your doctor to refer you. You can walk into a physical therapist and get alternative care. So I'm hoping that we keep moving in that direction, because we can't go on without mentioning there are people suffering from chronic pain today and who are legitimately using opioids. And I know that this discussion frequently makes them nervous. Mm-hmm. And I get it. And I don't know what the answer is. And but I know that, you know, we do have those folks in mind. We are not out to shut down all opioids. There is a valuable need. There's a valuable use for them. I'm not the doctor in the room, but we do have to keep that in mind, that we know that. And that's not what we're after. We're trying to really get down to the misuse, which so frequently leads to addiction, which so frequently leads to death.
Now, the state is, of course, as we mentioned, seeing quite a bit of federal money coming in to help stop this problem. Is there anything else that you wanted to mention as far as what some of that money is going to be going toward in the state? Yeah,
we're doing a lot of, I think, creative stuff. We're about to launch with the Boise Police Department, probably within the next week or two, the LEAD program, which is Law Enforcement Assisted Diversion. And Boise Police Department will select some individuals that in lieu of arrest, they will be offered treatment. And I'll let them talk more about that. We are also going to be working with some emergency departments. We know that once somebody we're hearing from emergency departments, people are showing up with an overdose, I'm treating them, and then I'm letting them go. And what we really want to do is have some, you know, can we get some recovery coaches there that can help guide that person and connect them to treatment, to the medication, to a life of recovery, because that's pretty frustrating, I think, for docs in the ER. We've got a lot of stuff going on with this. Some prevention. We're going to be doing naloxone distribution again through the Office of Drug Policy. We did that 2 years ago. We'll be doing that again, trying to get naloxone, the overdose reversal drug, out more into the hands of first responders, particularly in rural Idaho. In the future, we're looking at some creative projects with the Department of Corrections in terms of people that are being released from prison, in hopes of stopping that cycle. Because with this one, if we don't stop it quickly, the chance of death it could be the very next dose, right? It's not, some of the other addictions, I heard data one time that alcoholism on general, not counting car accidents and such, the actual disease can take up to 40 to 50 years to physically kill someone in terms of liver destruction and all that. The average with opioids is 7. Wow. Because some people are dying first, second usage. Some people are going years and years, but the time clock on this one, it just seems so much more urgent because of that.
Now I want to bring Jeanette Day into the conversation, because you see people, you know, time after time that have been dealing with this, and they get stuck in the cycle. And normally when you come across them, they've already been charged in some way, and they're going through the drug court process as a way to lessen the charge or seek this help and rehabilitation. Tell us about what the program does for people that are struggling with addiction.
Well, when somebody's arrested, first of all, it's a felony charge. So by the time they're getting to a felony, which is going to affect their life in so many ways, you know, with jobs and everything else, but most of the time, or in the past, a lot of times what would happen is they would either go to prison, or if they got put on supervision, I mean, probation is so overloaded with people. So what we offer is an alternative. It's actually an alternative to prison, not to probation. But when they come in, they have a felony charge. If they have to agree to plead guilty in the beginning of the program. And in the program, they're offered for, I think the charge now is like, it's very low. It's like $75 a month. And so they come in, they're signed up for classes, they take random UAs, they're assigned a color code, they have to call daily. If their color's called, they have a 2-hour window to get in and produce a UA. So there is a lot that they have to do, but at the end of the program, they will be clean and sober to graduate, and their charge will be dismissed. Now, if they come in as a back end, which is somebody that was on probation and they failed probation and might have went to prison, we call that a back end. They come in, if they do the program, then they can go on unsupervised probation, and then finally, hopefully, if they don't offend again, then they can have their charges dismissed or lowered.
What are the kinds of people that you're seeing coming into this program? Like I asked with Dottie, this isn't just one portion of our society dealing with this issue, right?
No, it's not. And a little bit different from what Dottie sees, because she sees a lot of, like she said, people that are middle class. We have a lot of younger people. We have, you know, the cheerleader, the football star that by some chance either got into using opiates or maybe got a prescription for opiates or started using, you know, a parent's opiates. And unfortunately, a lot of times those are the ones that we also see die of overdose. But most of our clients now, back several years ago, when I first started with drug court, there was about 75% methamphetamine. And that changed to now it's about 75% of the clients are on opiates or some form of opiates, whether it be heroin, whether it be oxys. You know, several years ago, before there was so much heroin use, a lot of the clients were smoking oxys, which are prescribed medication. And that's how they would use it. They don't take the pills, they smoke it because they're going after, you know, the bigger high. And now that we have somewhat cut down, now heroin's making a big comeback, and there's a lot younger people using it. And so the people that we generally see are young. A lot of them went to college, a lot of them come out of high school, some of them maybe not, maybe a lot have been in the legal system for years and years, and those are the ones that just keep going round and round and round and round. So what we offer is enough time and enough structure and accountability that they get through drug court. They have a fairly decent chance of continuing that, because by the time they get out, they usually have a good job by then. They're a productive member of society. Maybe they've been reunited with kids, with their family, and all of that component together gives them a better chance.
And you see some great success with the program, right? You see a lot of people that go through it all and they are holding good jobs and they're recovering now?
Yes, we see. I've had several clients, young, one in particular I can think of, that she had a major heroin problem. Well, it started out with pills. She was taking her mom's pills, and she's been graduated out of drug court a couple of years now, and she's doing really well. She's very successful. She comes back to groups now and again, not all the time, but she comes back and helps other people. And that's another thing that drug court also works with, is we have mentors, people that have made it through the program that mentor people that's coming in to let them know it can be done, because in addiction, addicts get discouraged because a lot of them come in and they don't know how to handle recovery or living life without a drug. They get very discouraged, and when problems happen or they can't get a job or whatever, they start to give up. So they've got to have that component of being able to see that other people are there and can, you know, have made it.
Now, is part of drug court also working with other individuals going through the same process? Are there group therapy sessions as well? Why is that so important for them to connect with each other?
Because Well, number one, when they come in, they start out with more of an educational type of a group, because that's another key component, is having the education about drugs, about alcohol, what's happened to their brain. I know Dr. Larson talked about that it's a disease and it changes the brain, which it does. So if they can start to learn those things, and they come into group sessions, they have assignments, they share those assignments. They also have group therapy, which is more of a process type of group, where they have a secure group of people that they can talk about their problems with, that they can have support from each other, that they start to, so they're not feeling alone and outside of, I mean, if one of the biggest relapse triggers is when people go back out and they start hanging out with their old friends. They may not want to pick up and use. I mean, they may really want to not use, but when they become triggered because of an old friend or an old place, the brain automatically triggers on that and they go into a craving. And so if they don't have these new supportive relationships, the chances of them being successful is not good. You know, they'll think just one more time, and it might be that one more time that kills them. And I see that, you know, it's just been recently. Young lady, very young lady, she picked up, she knew to go to detox, she went to detox. In the meantime, she was calling us, she was a graduate, but she never quite made it back in, and instead she overdosed and died. If she could have kept that core group with her, you know, there's a lot of help there because they understand each other.
Well, and the work you do is so important, and I know you are very passionate about it because you have history of this in your family, and you've been helping these people for decades now in the program.
Yes.
Do you want to say anything about how your personal connection to helping these other folks?
Well, yeah, I mean, you know, number one, I'm raising my 12-year-old grandson, and it's because his parents are addicts. It's because they're in and out of the system, and they're, you know, they go to jail in and out. I'm grateful that I can be there for him, but I also have to say that, you know, I'm in recovery from my own addiction problems, and, you know, by the grace of God, I have, you know, coming up on, well, I have 29 years, but I know how hard it is. I know how hard it is to, you know, if I hadn't, I remember my denial of I'm not as bad as this or it won't happen to me, and I could have died several times. I could have, but I was able to get treatment, and that's the other part of it is I've always had people around me that support my recovery. But this disease is it's so complicated that even raising my children, knowing that what I went through, and I raised them in a clean and sober home, I still have a child that is addicted. And so I am passionate. You know, I heard a client the other day in one of our groups talk about, you know, how he affected his mother. And I think that's the other thing is addicts don't always realize in their disease, because they're killing the pain, how they affect another person. But once they get clean, he was talking about how he affected his mother, and I so much related to what he said. What he was saying was the same thing I feel with my child that uses. And I think that impacts, that final impact when you can hear how you affected somebody else and start to realize that you don't have to do that anymore, is what really changes people around to recovery.
Well, I think hearing from all of you will help inspire others at home get to that point. We want to see if anybody watching at home has been asking any questions. Michelle, you seeing anything on there?
Yeah, we're having kind of a lively discussion, in fact, Karen. Sarah Elliott has quite a bit to say out there on our Facebook page. But this is coming at all of your guests right there, asking about drug court in particular, but looking at the legal aspect of the epidemic, of the opioid epidemic. Is there enough being done in the legal world? And I think this kind of comes off of drug court, where Shauna Loveland is talking about what needs to be revamped, maybe from the coroner's perspective, from the court's perspective, to make sure we are treating this as a disease and not as something that is going to send people to prison.
What do you guys think? Anyone want to jump off there?
Well, I can say, and this is one of the great things about drug court, is we work with the judge, with the prosecuting attorneys, with probation, with public defenders, with the sheriff's office, that everybody that comes into drug court has that team of people, and that they understand, because we do treat it as a disease in drug court. So that team of people are all on the same page for every client that comes in. We know that client, we understand they have a disease, and that is how we treat it. We still have the accountability piece. We have the treatment, but we have the accountability. And I think every addict needs that accountability, because addicts are not disciplined at all. So I would hope that the caller can understand from that. I think when they hear court, when they hear police, our probation officers are amazing with our clients. You know, and I've had probation officers say in the past that, you know, before, all they've seen, and the same with judges, all they've seen was people come in and out in front of them. And it seemed like people were not ready, you know, they didn't care. And now, because of drug court and because of that team approach, they see what people are really dealing with and how difficult it is. And so there is a lot of emphasis on treatment. And you know, some people call it candy bar court, because when they do something good, they get a candy bar, but that means everything to them. You know, it's not, but the candy bar actually leads up to having their charges dismissed in a lot of cases. So we are treating it as a disease and doing a reward and sanction to help them earn it, so it's not just something that they haven't achieved. Because if they can get through drug court, I don't think there's anything they can't achieve, to be honest with you.
And what would you want to say to the folks that maybe from the outside looking in, they see, well, this person broke the law, they should go to jail. Why do they get to go to candy court instead?
Well, they do go to jail. I mean, they start out in jail. And a lot of times they take those phone calls, or, you know, they call their family and they want to get out, and their family's saying, I've had enough. And they do go to jail, but then when they come into drug court, if they are not doing what they're supposed to be doing, taking all of those UAs, going to all their classes, they have to hold a job. That's a big thing that counts with accountability, is we have people that are actually contributing because they're working. Their wages increase, we have families put back together, so all of that really, really helps. So, but if they're not doing that, they'll end up going to jail, they'll end up going to the prison. So I think a lot of people on the outside looking in might say it's, why shouldn't they go to jail? But they do have a disease and they do need help with that disease. And as long as they don't run away, we can help them.
We want to thank all three of you for the work that you and your departments are doing to help become part of the solution here. So thank you for joining us live in our forum. We'll go ahead and toss it over to Michelle with an expert panel on treatment. Michelle?
That's right. It's time to talk about treatment. It's time to talk about how people can get out of the disease that is going to plague them and has plagued them. So let me introduce you to our guests. Jason Austin is here from Raise the Bottom, Debbie Thomas from the Walker Center, and Norma Jagger from Recovery Idaho. You three are on the front lines of this every single day. So answer this. How bad is it really?
It's bad. It's bad. We see it across every socioeconomic level, every gender, every race, every possibility that you can think of. It is your loved one, it is my loved one, and it's bad. People are dying, and death is hard, but to see the suffering of what people are living with and the hurt and disappointment that they've caused for themselves and their family members is the sad part too.
And how far each of them will go in this disease, because we treat 18 and up, and so we'll have 18-year-olds all the way up to 7-year-olds in wheelchairs who are still using IV heroin use, and so it's detrimental. We have attorneys and we have people living in their cars, so it just affects everybody.
Why aren't people talking about it more then? Why is there such the stigma attached? I was talking with the medical professionals earlier about disease versus stigma and those words. Why is it that there is still this stigma attached to opioid addiction?
I think it's not just opioid addiction, it's addiction. We are really hurtful to other human beings. We're not kind. And it doesn't matter whether it's somebody drinking too much alcohol, somebody using too many pills. We present, and this is Facebook Live and those kind of things. We present as we have everything together and it's all good. And somehow our society has lost the ability to know that everybody's raw, everybody's struggling, and we don't want to talk about the ugly parts of life. And so I think that is stigma. Stigma is that it's not okay. And I think the other reason we're not talking about it is that people have lost hope. We've really criminalized things. We've gotten behind the curve on how to help people. And so people don't realize that if you talk about it, there's hope. We really, as treatment providers, we know what we're doing. We don't have the opportunity often because there's financial limitations and being able to have people in treatment for as long as they need. This is a chronic progressive illness, and if we treated it like others, people would have better outcomes. And so we're not talking enough about it, so I'm really grateful today that we are talking about it.
On Facebook, thank you, where we can be raw and real and have you have your comments out there. We'd love to hear from you. Norma, who comes in? Who comes in asking for help? Are they dragged in?
Well, I think people come in a variety of ways. Sometimes it's not the person themselves. Sometimes it's a spouse, or it's a parent, or it's a child, or a brother or a sister, and they're watching a loved one caught in this spiral. They see them destroying their lives. They experience them destroying their family relationships. We have Thanksgiving coming up, and Thanksgiving is almost, sadly become sort of a joke about how bad it's going to be at the Thanksgiving table with your family, and so seeing all the devastation. I have a good friend who is spending this week going to the hospital for 4 hours a day to sit with a baby who she's going to be a foster parent for, who is in withdrawal in the hospital. So the devastation and families being torn apart and feeling so powerless. We talk about addiction as a disease. I think we've got a long ways to go before most people really accept that. I mean, we accept that. We understand from the research that's been done really in not all that many recent years to understand the changes in the brain and how, most of us think that we're really in control of our behavior. We do things out of some sort of rational plan, but when the brain becomes so changed because of the impact of drugs, they're operating out of a sense of survival that's become distorted. So we have families that come in. We have people that come in who say, I can't do this anymore. I don't know where to go. We have limitations in our system across many different ways in terms of being able to access treatment, to afford treatment. I've worked in drug courts for the last 18 years and often hear people say, why does someone have to break the law in order to be able to get treatment? And sadly, there's a lot of truth to that. So people come in a variety of ways, sometimes on their own, sometimes for members of a family, and really not understanding where to go, not knowing where there are resources. And that's where the 9 recovery community centers around the state can offer a map, can offer a pathway. They understand the resources, they understand the systems and how to help people, have hope again and to believe that there is a solution, there is, a light, truly a light at the end of the tunnel.
I have to tell all of you, and Jason will laugh, because to be very honest and real, when we started looking into how we as Six on Your Side were going to approach this massive issue of the opioid crisis, I had a chance to meet with Jason, and the light you shed on the entire crisis for me, from changing literally what we were calling our segments. We were talking about conquering addiction, and he's like, oh, no, no, no. You never conquer addiction, to finding hope, which I'm hearing from you. But Jason, talk to me a little bit about the education you gave me about how opioids literally change the brain, and how you have to work within that in treatment to get somebody the help they need. There's so much neurological research to what has happened. Can you shed a little light on that for people who don't really understand what opioids do?
Yeah, opioids are so much different than any other substance out there, and the way they take over the brain and start to manipulate the pain receptors and create more receptors because of tolerance, and it's just over and over, and then it becomes a physiological piece that withdrawal, and like the doctor had said, within days that withdrawal sets in, and that's the trigger that continuously brings people back, and that's why, back into relapse, because most of these other substances you can usually go through a detox, and the physical portion isn't there. That detox after, it's not going to creep up all of a sudden on you, 2 weeks later, a month later with some other withdrawal. That's not the way it is with opiates. Opiates, you can go through a 5-day detox, but oftentimes it continuously comes up for months after months, which triggered people right back into relapse. And so that's why, a lot of the research shows that we've got to use a medication on top of the treatment. And the treatment being, the counseling portion, and that's absolutely critical. But we got to get the person able to be able to sit in the office to have a treatment session with the provider, with the counselor. So we've got to stabilize their body and their brain enough to want to pay attention and focus, instead of focus on where am I going to get my next fix and how am I going to not be sick. That's the biggest thing. How am I going to not be sick anymore? Because
you're talking about being sick during that detox, supposed detox process, or when they're doing that. And from what I've heard from you and other people, it's horrid. Like, you don't want to go through this. This is not something that you just get through in a matter of a day or two.
Mm-hmm. For somebody who hasn't been through it, they describe it as the worst flu you ever experienced, with the most intense body aches and sweats and vomiting and diarrhea that you could possibly imagine.
Yeah, and then it's not necessarily over, as you said, because the receptors are there.
So imagine trying to go through that and try to live your life, try to be a mom or a dad, and try to go to work, and try to, the options are slim for them. I'm gonna fix this to make sure I'm not sick so I can survive.
Oh. Talk a little bit about MAT. What is MAT, and how has it come to play a role in treatment?
MAT is medication-assisted treatment, and it's interesting how with the opiate epidemic, MAT's become more well-known, but MAT is nothing more than what we do all the time in Western medicine. It's medication assisting a treatment. So a diabetic utilizes a medication to assist their treatment, which is changing their diet and their exercise. So in an opiate-dependent person, the MAT is utilizing a medication to help stop the withdrawal, decrease the cravings, so that they can engage in the treatment portion to be able to hopefully have lifelong sobriety. The treatment portion is the key piece. It works together, but people forget that the treatment is most important. Why do I always want to pick up? Why do I want to always not have to feel what I'm feeling, right? So that's what MAT is.
How do you get there? Debbie, with treatment, with getting somebody in and actually getting them talking? Because I can understand where, you know, I show up at Raise the Bottom and I say, I need this help, give me some more medicine. Like, that feels natural to me. But how do you get people really digging down into the root cause of what's happening? Because that is the stuff you don't want to share.
Right.
You don't want that out on Facebook, you know?
Absolutely. So the important thing that I would want to say is that first we have to tell people that we're proud of them and that this is courageous. Because if you can imagine what we just said, is you feel terrible and awful physically, but you feel terrible and awful, you're ashamed of what you've done. And people think you're bad, but you're not. So the first thing that we do with treatment is, you know, treat them kindly, encourage and welcome them, make it as easy as possible. And that's why we need lots of pathways into treatment. Bring people in, and then once they're in the four walls of treatment, whether that's a residential setting where they're staying there or it's an outpatient setting, giving them the opportunity to have some meaningfulness and the hope. So what we've known for years and years is that spirituality and purpose in your life, alcoholics and drug addicts, and we're talking about the opiate addicts, they've become so isolated. Everything is about them and what's happening in their own head, which is all very negative. So getting them to realize that there is hope, you know, your body will stop hurting, and you can reconnect to people that you've disappointed. You can reconnect with yourself. So for us, you know, AA, Alcoholics Anonymous, Narcotics Anonymous, Celebrate Recoveries, all the things that get people connected to each other is important. That's the foundation that we all in treatment, whether you use medication-assisted therapy or not, we all want people to get connected to other people, recovery centers, churches, fellowship halls. But how we do that is to put treatment, the treatment pillars. And I like to describe it as the person that had a heart attack, the doctor goes in and maybe does some surgery, you get some medicine, then you go home to a loving family who says, we're going to get you to physical therapy, and we're going to change your diet with you. We need to do those same things for people in recovery from alcohol and drug addiction, is we know what we're doing now. This is an infant recovery approach, but we know cognitive behavioral therapy works. Trauma-informed therapy. We need to help people figure out what happened. Bad stuff is happening to people, and we want to numb out from it. So whatever that trauma is, we as clinicians know how to treat the trauma. We know how to change people's behaviors and thinking, and to offer that hope. The last thing that I would say to everyone, whether it's law enforcement, family, keep bringing people to treatment and keep them engaged for as long as possible. It's not necessarily going to work the first time. It does for some people the first time, but you have to keep bringing people back, keep reducing the shame and saying, okay, what did you learn the last time? Let's build upon that, and keep people in a continuum for as long as possible. Start with residential, end up in an intensive outpatient. Get your family of choice, your friends involved, get open and speak about what you need from them, what you don't need from them. Get into recovery communities, and have fun. The thing that is amazing is to talk with people that have 5 years, 1 year, 8 years, 20 years. Life can be joyous and fun. It gets easier every day that you stay sober. So know that there's hope.
What about the rural aspect of our state? Is there enough treatment for the people we need to treat?
Well, I think there isn't enough treatment anywhere, rural or you know, population centers. But in rural areas, that can be, you know, Debbie talked about the isolation, and rural communities can be even more isolated than others, and that connection with other people, which is so critical, and connection with people who have walked the path of recovery, who are walking the path of recovery, who show, not just tell. I mean, it's one thing to tell someone you can feel better, you can feel joy again, you can have your family back. It's something very different to see someone who has been there, who has joy again, who does feel good again, who's healthy again, and does have their family back. So that peer-to-peer relationship is critical, and that's more difficult in rural communities than in communities with more resources and more people to be connected with. You know, probably the two things that we've talked about a bit already that are so important are dealing with the issue of shame. Shame being such a trigger. I mean, when we feel ashamed, you know, we'll do almost anything to kind of get away from that. And too often that means going back to drugs, going back to that one thing that we know works immediately. We know that temporarily, you know, but temporarily it works. And the other is the issue of hope, that tomorrow doesn't have to be what today has been. You know, that's not a direct path, and that's where the recovery community centers are filled with people who are living great lives in recovery, lives, they will tell you, lives they never imagined could be possible for them. You know, even before they were so caught up in their addiction, never imagining that they could have the kind of life that they've achieved. You know, a life where when the telephone rings, it's not a bill collector. You know, when the doorbell rings, it's not, you know, it's not some new disaster. When their kids come home, it's not because, you know, they got in trouble at school. So the life that many of us may take for granted is a life that can be unimaginable to the people that we deal with. So helping them to see, yeah, it can be that way. It can be that way for you because it was that way for me. I've been where you are, and look at me now. So rural communities have a greater struggle, but sometimes rural communities have a greater sense of community also.
Interesting.
One thing that the Walker Center offers is we have telebehavioral health, and we started that a couple years ago to meet those needs that some people just physically can't get to treatment, or they're working a job and they only have an hour to take their lunch, and it's a 45-minute drive someplace and drive back. So it's a simple app. They can call and make a counseling appointment and do their counseling online. Good quality where you can see the counselor, connect with people, have an opportunity that you don't have the barriers of transportation and being isolated in your small community. So.
Well, and Jason raised the bottom. You guys have expanded. It just shows, and it's not necessarily because we've had growth in our area, it's because the growth has happened in this crisis too.
Right, we needed to get further out into the rural community to be able to help more people. Exactly.
All right, let me put you guys on the spot. Okay, we talked about, you know, distance and rural versus urban. What about money? You know, is there more money needed for treatment? Are insurance plans treating this in the appropriate manner to make sure there's money to help people get treatment if they need it? Is treatment too expensive? Where do you stand on the issue of finances? Because money comes right next to, you know, family when it comes to figuring this stuff out, right?
Absolutely. So I take the answer first that third-party insurance companies, you know, the ones that our employers are offering or you can buy through the health exchange, are treating the disease of addiction. So we're able to get people in that have insurance. The challenge is that they don't understand the dosage of care that's needed. They'll offer 3 days or 7 days or 10 days. And so my clinicians spend an awful lot of time talking to insurance companies and a review manager who's asking us to prove why the person still needs to be in care.
How frustrating.
And that's very frustrating to have clinicians who went to school and got training to learn how to teach people and take care of people that spend a lot of time that way. Unfortunately, with Medicaid does not have a full continuum of care in the state of Idaho. We all have a challenge there, so the expansion is a possibility that could help with that. The cost of treatment, if you cash pay, we'll have people all the time call and say, I can't afford treatment. And when they talk to our admission team and realize you can't afford it because look how much money you spent on attorneys because of stupid stuff, or off work because you're taking care of that loved one, that you know, Walker Center in particular is a very low cost point. We work with people trying to get them on payment plans, but there isn't enough money to help people at this point, but we can't afford not to. You know, I would say families need to connect, you know, have your own decision about whether you have resources, time, and talent that you can put into, but families, this is not just the loved one that's using that's the problem. Everybody has to be part of the solution.
True. And there's kind of a catch-22, I think, going on right now as we talk about the, you know, the opioid epidemic, more people getting caught up in it. We have more treatments, really evidence-based treatments available, medication-assisted treatment, other psychosocial treatments. We're publicizing it more. We're actually seeing growing demand, growing need. We have not really seen, with the exception of the recent kind of federal funding that's been made available. You know, the federal government estimates that it's really only 1 in 10 individuals who are in need of addiction treatment are able to get it, 1 in 10. So the more we are successful in helping people understand treatment does work, treatment is available, the more we increase the demand, you know, we're not increasing the resources anywhere near reaching that, that kind of threshold. We talked about drug courts. You know, drug courts could enroll additional people, but we don't have resources for the treatment that's an essential element of that drug court program. So yeah, there are increases in funding now available, but it's not going to match the increase in demand and the increase in need. So that's going to be one of the major challenges. Hopefully, you know, the Medicaid expansion will open up avenues for treatment for people that have not had eligibility for any kind of assistance for treatment. Often when people reach the point of being ready for treatment, they've exhausted a lot of resources. They've lost their job. If they had insurance with an employer, that insurance is gone because the job is gone. You know, you know, they've already mortgaged the second mortgage on the house. So yeah, funds for treatment are a major issue.
You see it too, Jason?
Yeah, I think definitely because, you know, in an opioid treatment program, you know, in Idaho especially, and MAT is still quite stigmatized, especially in Idaho. So we've struggled with a lot of the commercial insurances and a little bit with Medicaid as well. So that, you know, they cover specific parts, you know, different services, but as a whole, when they see an opioid treatment program and everything that goes on inside of it, in a lot of states they cover bundle packages, they cover the entire thing, everything that goes on. But in Idaho, we still struggle with well, some of the services the patients end up having to pay out of pocket, you know, and we help them as well with different sliding fee programs and different assistance here and there, but it's always a struggle, and that's one of the biggest reasons, one of the biggest barriers. It's transportation and finances that people leave treatment, you know, and so all the time.
Got to get that figured out. I know Karen's watching our Facebook page, so we hope people are being real, right, on there. And Karen, what are you hearing and seeing?
Well, Sarah Elliott is writing, I'm glad these treatment centers are available to those that need it. Jubilee Darrow then says, I wish there were more treatment centers for those who want it. So I guess my question is, do we need more treatment centers spread out across the state? And for the people that are watching that may be realizing, I do need treatment, what is that first step? And what is the first call they should make, the first appointment they should make? How do they walk through the doors that very first time?
So there's nothing wrong with needing more treatment centers, but the treatment centers, my treatment center is not full. You know, the other treatment providers that I know, our centers are not full. There is capacity to meet the needs. Funding is the biggest issue for a lot of people, but all you need to do is make that phone call. The staff at every treatment center, including the Walker Center, we know how to navigate. If you have insurance, we'll help you by calling and pre-certing and what's your deductible and co-pays and all that kind of language that might be overwhelming.
Crazy, scary language.
It's a scary language, and we know that language, and we will not surprise you. We will estimate what it's going to cost and tell you up front what it's going to cost so that you can navigate that. If the family member wants it more than the loved one, have the family member call. You know, we have moms and dads and husbands and wives calling all the time, or brothers and sisters. Call. We can talk the person through, you know, how can you talk to your loved one and encourage them to come to treatment. What's the right level of care of treatment? Starting with the assessment. You know, if your loved one's not ready, just sharing with them that you're hopeful that things can change and that you're not mad at them, and just being there. If we could join with the person and walk beside them, just call. That's what treatment centers want. Just call us.
Jason, you're nodding.
Yeah, that's the first step. They've got to step out and make that call, have the courage to make that call and say, I've had enough. You know, I think, you know, we oftentimes have to say, we can't help you, and we have to rely on other modalities of treatment to, you know, that they've got too much going on. They need an alcohol detox as well as, you know, there's a lot of polysubstance with addiction, and so, you know, we just want to help. So, you know, when they call, that's all, like you said, that's all we're looking for. Just call and we will get you lined up and directed and referred to, you know, somebody else that, if it's a finances piece, then hopefully we can get you going down that direction, and there'll be enough resources, there'll be enough people, you know, if we team up, if we are always working together to be able to, like, I can't do this, but they can, you know, and they can help you.
The treatment centers are not competitive. We really are collaborative with each other across the full continuum of care, and we refer the person back to each other. So just getting more resources in to where there's more options for people to be able to come through the doors.
And I would say also there are 9 recovery community centers in the kind of the major cities across the state. They can help you access treatment as well. They know the resources in the community. And not only for treatment, but to help you find, you know, housing is a huge issue. It's a huge issue everywhere. It's certainly a huge issue in our state. Housing that is safe and sober and supportive. Other kinds of basic needs, you know, food, shelter, helping you to identify other resources that are available in the community, including helping you to access treatment services that are available, helping you find a program that meets your sort of needs financially as well as clinically.
Mm-hmm. And it's okay just to pick up a phone, and just say,
I need help.
And let you guys take over from there.
Absolutely.
My final thought would be, don't let money be the barrier, because if you ask to anybody that's been in long-term recovery, they spent more money on their addiction and staying sick than they ever spent to get well. So it's also a myth that money's going to be the barrier. It is in one way, but people can do what they need to do when they want to do it.
Thank you all for being the heart of this community, for being the people on the front lines, for everybody out there. And if you are nervous or scared, or you think you know somebody who needs some help, these are the amazing, wonderful people who will be on the other end of that phone when you call and just say, help me. So thank you to all of you for what you do in our community. I appreciate it. Karen?
All right, well, another group of people on the front lines of this issue in our state, of course, law enforcement agencies all over the state of Idaho, not only dealing with the addicts, with the drugs coming into the state, but now also becoming part of the treatment solution. So we want to bring in our next panel of experts. We have Captain Eric Daly with Idaho State Police. We have Officer Terry Weir with the Boise Police Department, and Greg Lewis with the Idaho Department of Corrections, specifically with the Parole and Probation Division. So thank you all for being here and being willing to talk about this with us. And you are on the front lines of this, and you guys see it more than most people. And even when you hear the term opioid addiction, you may even be already having faces and names pop into your head, because you often see the same people time after time. So I'll start with you, Officer Weir, here in the Boise Police Department. You guys are making some changes now, and a new pilot program to kind of change the way you guys are thinking and dealing with this issue. Go ahead and just tell us from the beginning what you guys have been seeing as a department and what's changing.
So basically, we saw an increase in overdoses. We saw an increase in opioid activity, so whether that's pills, syringes, the overdose calls for service, along with the correlating crime that goes with that. So a couple years ago, we started paying attention to that and tried to figure out what was driving this. And at the end of the day, it comes down to it's an addiction issue. Substance use disorder is what was driving most of this. We found that there were a lot of good people out there that became addicted through anything other than illicit drug use. It would be an injury, whether it's on the job or a sports-related one. Normal people, they're just good people that all of a sudden, next thing you know, they're either injecting or dying buying of heroin or fentanyl or any other type of opioid out there that wouldn't fit our normal, what we consider to be a normal drug user or a normal criminal, for example. Looking at it from the human side, we had to figure out what we're going to do to take care of this problem. And I'll borrow the phrase that I've heard over and over again, which is you can't arrest your way out of an opioid problem. So we started looking at what can we do to maybe stop this besides just arresting people and putting them in jail. We saw that we would have the same addicts that we would arrest over and over again if they weren't overdosing and dying. So obviously just putting them in jail wasn't the only way to solve this problem. We still have to have the enforcement piece because we have to stem the flow of narcotics coming into our community, but we also recognize we have to have an education piece and a treatment piece to go along with that, and that's what we're focusing on now.
And a lot of these people that find themselves victim of opioid addiction, they're not even committing drug-related crimes a lot of the time, right?
Sometimes they are. A lot of times we'll catch them burglarizing a store or a car or somebody's house, and you'll ask them why they're doing it, and they say specifically they don't want to go through the detox or the withdrawals that come along with not being able to get an opioid into their system. And so that kind of what drives a lot of our correlative crime that goes along with that. There are some people out there that are just going to be criminals. They're going to continue. If it's opioid one day, it's methamphetamine the next. But this isn't really what that's about. This is about the true addict that really never wanted to get into this lifestyle and really doesn't know what to do to get out of it. And then they come in contact with us.
And so we'll jump right in and kind of talk about the pilot program that you guys have begun. We spoke briefly about it with Rosie Andueza, who was on earlier with the Idaho Department of Health and Welfare, because that's where the money has come from. And this is in the very beginning stages, I know. Have you guys chosen any of the participants yet, and explain who you're going to be looking for and what the pilot program is going to be doing?
So we haven't selected anyone yet. The program should be up and running here in the next week or two. We are going to do it based upon calls for service, or if we go out and we take a proactive approach with identifying people that would maybe fit within the parameters and the criteria of what we want for the program. But the most important thing with this is that we want to find people that want the help. And unfortunately for a lot of these people, they don't have jobs. They're not necessarily looking for the normal ways that people that maybe are gainfully employed or don't have an addiction issue, looking up how to get the help. A lot of them don't even know what's out there to look up. They don't even know what that help would be. And so a lot of times that then falls to us. And so we're kind of the last rung before they end up going over to the IDOC. Law enforcement, we kind of catch them on those calls, and we're going to look for those type of people to go, hey, this person fits, they want the help, they don't know where they can go to get it. We're going to try and get them those resources through health and welfare. And
go ahead and touch again on the different people that you see dealing with the same issues. They come from the upper class areas of Eagle. They come from, the lower income areas of different counties across the state, but it's the same issue and people are dealing with the same things.
Yeah, that's very true. There is no demographic that this fits. It's not a socioeconomic issue. This can be anybody, and we're seeing it from everything from kids. I mean, we've had overdoses of children that have gotten into their parents' methadone, for example, and are overdosing, all the way to functioning addicts that are elderly that have been prescribed stuff for long-term pain care that die from an overdose because they're taking too much of it. And then of course you still have the normal thing that you would picture of what an addict would be, a junkie shooting up in the back alleyway, all the way to the star high school athlete that gets injured and next thing you know he's addicted to pills and then he's going to heroin. This impacts everybody. And you asked about names and faces. I personally do know people that have become addicted to this, and I'm the one that talks to a lot of the parents who've lost children to this. So it touches anybody and everybody.
And I want to bring in the Idaho State Police side of things. And you come with us. Thank you for making the long drive from Pocatello over in eastern Idaho. And from the stories that we've done in the past, we've learned that's where a lot of the street drugs of this side of things kind of enter our communities here in the Treasure Valley through other states and through other highways. What are you guys seeing over in District 5, and where are the street drugs coming from?
So I guess pointing the finger to the south is Salt Lake. That seems to be the drug hub of eastern Idaho, at least. That's where most of the drugs are coming up, from Salt Lake. For people on the eastern side of the state, it's a quick trip to Salt Lake. The drug laws in Salt Lake are more lax than they are in Idaho. And so people just trip down to Salt Lake. It's a quick trip down and back, and they buy their drugs and then come up and use and share with their friends and deal as well. So that's kind of where we're seeing is coming up through I-15.
And how common is this, and how much of your department and your district is focused on this issue?
So we're all focused on it. It is a huge issue. It's interesting to talk to different community groups like Rotary clubs and things. Most people are oblivious to the fact that we have a horrible drug problem in Bannock County. Recently, we were designated as a HIDA, which is a high-intensity drug trafficking area by the federal government. That brings some funds in with that program so that we can do interdiction and do further on drug enforcement. We are partnered with the Drug Enforcement Administration, and we're trying to make some inroads. And actually, we have done some huge cases lately over there, and actually it has surprised people how much weight there is on the street in Bannock County, in Pocatello specifically, how much quantity of drugs that there are. There's been some even long-term veteran police officers that were shocked at the amounts of drugs that we've been taking off of the streets in Pocatello. So methamphetamine has been with us for many, many years, continues to be a drug of choice for a lot of people. A few years back, people kind of switched to pills, and so we saw a lot of pill cases there for a while, and then all of a sudden it just switched to heroin. And we have seen people that the first illegal drug that they ever used in their life was heroin. They were at a party, they just decided to smoke some heroin, and they did it. So there are some, I know people talk about gateway drugs and things, and people kind of build up to heroin. That's kind of the big monster out there. But we're seeing people that's the first thing that they've ever used is heroin. And it's pretty scary. It's a horrible drug. I know I've been watching some of the other segments you've done so far, and there's a lot of issues that go on with that. And so actually talking to Officer Weir, it's exciting that they're doing some, you know, we're really focused on the enforcement part of it right now, but I'm excited to hear about education and rehabilitation and treatment, because that's really what we need to focus on. That's, as a society, that's where we need to, first of all, we need to recognize that there is a problem. And I'm not trying to belittle people, because it's great that they live in Happy Valley and that they think everything's fine, but I want them to know that there is a problem, a big problem, and we need to do something to solve it.
So hit them with the big numbers then. What have you guys recently pulled off the streets? You said it would shock even veteran law enforcement officers. You
know, they're pending cases, so it's kind of hard to get into specifics. And the way that we investigate drug cases is we kind of start out small and work up. We target mid to upper level drug traffickers. And so I'll just say, you know, in the last few months, around 50 pounds of methamphetamine out of Pocatello and several pounds of heroin. It's a lot of weight that's out there on the street.
And when you hear a pound, I mean, that's enough to get.
So when people use heroin, they typically use it on a point. They use a point of heroin, which is 1/10 of a gram.
Okay.
So typically they'll buy a gram of heroin, but so 10 points equals 1 gram. And on the street, it's going for about $140 a gram right now. So they'll buy a gram, and then that's 10 dosage units, basically.
Wow.
So divide that into ounces and pounds, and that's a lot of heroin.
And a lot of users that it is then ending up in the hands of.
Yeah.
So I'll go ahead and bring Officer Weir back into the subject. You brought up the importance of education, and a lot of these kids now are starting out right away by trying heroin. And you guys have been partnering with schools in the area to kind of be part of that preventative effort. What are you guys doing as a department there?
So we partnered with the Boise School District. They've been fantastic to work with. They recognize that they've had some issues as well. You know, whether it's students that have been overdosing or if it's parents or family members, I mean, they're aware of the problem that's out there. And for me, one of the biggest things that we can do is educate not only our young people, but also the parents about that stuff so they can have those conversations. When we go into the schools and we talk to them about this stuff, this may be some of the best and only education they get, other than what's on Facebook or YouTube or whatever's out there on the internet that I certainly wouldn't trust. They're getting it straight from us. And you know, the captain was hitting the nail on the head with some of the community issues that we have, and as far as it being a social issue, you know, because some of these parents don't think that we have an opioid problem. That's, you know, this is Idaho. There's not necessarily heroin. What is heroin even? How did it get here? Well, you know, then you have to look at the basic economy of how this whole thing works, which is prescription pills. The viewpoint of that is that, you know, doctors prescribe them. It must be medicine. It's good. I mean, we kind of miss the boat with that. And parents kind of fall into that same trap. They're not police officers. They're not social workers. They don't work at the, you know, inpatient facilities, so they're not necessarily aware that this is even an issue until their kid is stealing money from them, their kid is overdosing, they change things that they're doing, they've lost their job, they're no longer their sports or social circle has changed, and then parents are like, what do we do, and it's too late. So targeting, or I wouldn't say targeting, but partnering with the schools has been just as big of a step for us on the enforcement side, and just as big as what it'd be for treatment, because we have to educate the kids and also their parents.
Nice. Well, I want to bring in Greg Lewis here into the conversation with the Idaho Department of Correction with the Probation and Parole Division, because you guys are also working on a new pilot program that is kind of a new approach, at least in our area. It's been done in other states, but tell us what the pilot program is all about and what it is that you guys are trying to learn from this.
We're doing a pilot program with Terry Riley Health Services and Recovery for Life, two providers here in the Treasure Valley, to work with opioid addicted offenders to see if we can figure out the best practice to work with this population and to bend the curve on recidivism and help them be successful. The pilot is going to be about 50 individuals once we reach full capacity, and we'll serve that population for about a year. And we'll see how they succeed, hopefully, in the pilot. Involves medication-assisted treatment through Terry Riley Services, and that would be a daily dose of Suboxone. That would help that individual with their cravings and stabilize in the community so they can function in other aspects of their life.
Tell me kind of what the main goals of your whole department would be when it comes to rehabilitating people and making them functional members of our society once again, and why this can now play such a key role for a very specific population.
Yes, thank you. So the department does have a slightly different role than other law enforcement agencies. We have that dual role of public safety and rural compliance, but also the rehabilitation of our offender population. And what all the research shows is programs, education, and treatment is what changes behavior. Simply rules and punishment, that alone does not change behavior. You have to give people those opportunities to change. So departmentally, we've done a number of things. Internally, we, in the Department of Correction, obviously we have the prison system, and we've revamped our programmatic services for that population. Every individual who enters our institution is assessed for a psychosocial assessment. We figure out what their needs are, what their security level is, and what programs and education we can give them. Upon release, the Department of Correction has probation and parole officers. And those officers supervise individuals direct from court supervision, so probationers, and then parolees are the individuals released from prison who are on parole. And the officers then not only monitor compliance, the law enforcement portion, but also they're a broker for services. We have a number of services available for substance use disorder services throughout the state, and those officers help broker those services and monitor compliance.
What are you guys seeing so far in the pilot? Have you learned anything yet? Have we selected enough individuals to really follow it quite yet?
It's early. We're not even 3 months into it, but we're already learning, and that is the goal of the pilot, is that we can go back to our Board of Correction and then possibly legislatively to make recommendations on what we see as working. And what we are seeing right now is this is an outpatient program. If they're too high in acuity level, if they need residential services, they're probably not the most appropriate individual to be doing a community-based outpatient service. As well, if they're so destabilized, if they don't have any of those anchors in the community, employment, are they still reporting to their officer? Is the individual, do they have a residence? If they don't have some of those basic anchors, they're so destabilized, then they probably need to go to a residential placement program or even a possible period of incarceration just to stabilize them and then release them back to the community.
That's what the pilot program's all about, right? You're learning.
That's what we're trying to learn, and what we want to do is be good stewards of taxpayer dollars. So the pilot will give us a good focus, and in a year from now we can make those recommendations on, okay, this is what we see is going to make the biggest difference in our community.
All right, well, since you brought up the taxpayers, I'll go ahead and ask both of you, because your departments are both working on these pilot programs that, you know, to some people would be controversial, and to be spending taxpayer money or federally funded grant money to go toward medication or treatment for people who have broken the law. You put it very well, Officer Weir, in the past, that you're still paying for it in the long run if you're not helping them. go ahead and speak on that if you don't mind.
Sure. I mean, it kind of falls with the, you know, the ounce of prevention, pound of cure thing with this. You know, if you look at whether it's calls for service that we respond to, your tax dollars are paying for me to respond to that, my officers to go to it. The same thing for EMS. The same thing happens at the hospital when, you know, EMS revives them and they go into ICU and you're looking at tens of thousands of dollars for a stay there. We're all paying for that still. And that doesn't even include the, you know, the dollars that go along with crime. You know, whether it's your vehicle being broken into, house being broken into, your insurance may cover that, but once again, we pay for that too. And not only that, but you also have to look at the, you know, the fear of crime itself, which is, you know, who wants to live wondering if their house is going to get broken into every day for somebody that's trying to feed an addiction issue. And then that also goes as far into the jail population and the prison population as well, which is the economy of opioids basically, which is what's that going to cost us to house them there. Well, for me, you know, if you look at the dollars and cents for it, it's cheaper to deal with this on the front end and try and get them some help for their addiction, their substance use disorder, than to, you know, put them in prison or in jail every single day and maybe not get the best care out there. So.
Now, is there, obviously, you guys all come across this on a regular basis, but there are people in our communities that are watching our stories that they just don't think that this is an issue in their neighborhood. Any one of you want to speak to that as to what you are seeing on a larger scale when it comes to the opioid issue in our state and in the Treasure Valley?
Well, I think you know, the point was already made, and from watching the other segments, I think the other participants also made the point that people need to pull their head out of the sand and see what's going on. And if you don't believe it, then talk to the local prosecutor, talk to your local law enforcement, and ask them what kind of problems are we seeing. Talk to school counselors, talk to other people that you trust that will give you the straight scoop, and I think everyone will tell you that there is a problem. You know, it's been interesting for me to watch and to listen to all this, and you know, we're starting this program, we're starting that program. Everybody's trying to do the best they can to kind of catch up to the wave, because this has just hit us so hard, and it's nationwide. It's not just Idaho, of course, it's nationwide, and everybody's trying to do their very best. And I think we need to pull together as communities and work together. Number one, like I said, realize that there is a problem, and then do what all what we can to help solve the problem, because it's a huge problem. It's going to continue to increase, I think, and get worse if we don't do something. And you know, my hat's off to these agencies that are doing things to try and solve the problem. You know, enforcement's only one part of the solution. And like Officer Weir said, we still need to do enforcement. That's very important, especially if we can take those mid to upper level drug traffickers out of commission. But we have to remember the reason they exist is because there's a demand. We have a demand on our streets and in our communities for these drugs. And so we need to do the treatment, the education, and to try and help stop the demand as well. If there's no demand, there won't be any drug traffickers.
And I'll add to that too. I present on this quite a bit, and I start off with telling people that are like, you know, why do we care about this? Well, I'll tell you why, because I guarantee you that every person in the room at one of these presentations either knows somebody or is going to know somebody that has an opioid addiction. And it's one of those things that, like the captain is saying, as a community, we all have to get together. That's why we're here talking. That's why we have treatment providers here. That's why we have, you know, physicians and pharmacists. We all recognize that we play a role in this, and there's not just one person or entity or agency out there that's responsible for fixing the problem, because it's a social issue across the board. It's just, we just play a part in that. So for anybody that thinks that, you know, that this is just Idaho and it's not hitting here, if you have prescription pills that a doctor's prescribing, then I guarantee you have an opioid issue in your community, whether you know it or not.
So one of the piece of information here that I have found interesting is, you know, when I first started my career, more people were killed in motor vehicle crashes than anything else, you know, all the other things combined. And that has been eclipsed by deaths due to overdoses now. So there are more people that are dying from drug overdoses than there are who die in motor vehicle crashes. So, you know, if people think that, well, that's not in my community, that's not in my family, that's not, they need to wake up and realize that it is here, and we need to all do something to resolve it, to solve it. Just like we've had these campaigns, wear your seatbelt, and, you know, wear a helmet when you ride a motorcycle, put your child in a car seat, all these things. We need to do those kinds of things to attack, to address the drug problem.
Karen, I would say it crosses all socioeconomic boundaries, all religions, all races. We, in Department of Correction, we supervise the individual as a sentence to us. And I think the key is that social support network. The people that I see that are successful, they have that support network. And we heard earlier from some of your speakers, the proud mom who watched her daughter transform. This is key. It's, as we were saying, crime is not a Department of Correction issue. Crime is not a law enforcement issue. Crime is a societal issue. And if you have that support network for our population and you're serving their various needs, then you're going to have those better outcomes. What we have seen in our agency is the best outcomes come from treatment engagement. And the people who engage are the people who have more of that social support network. If they've been so destabilized they don't have those resources, those individuals don't do as well.
And very, very important. And we saw that Cassidy's mom never gave up on her. So if there's one takeaway, just continue to support your loved ones, right?
You never know when that moment's going to happen. We see the revolving door, but that revolving door does stop. There is hope. And I've seen people that you maybe on paper you would think weren't going to be successful, and they've transformed their lives. So people can change. That's one of our belief systems in the Department of Correction, and we see it every day. And I'd also like to add, I want the public to know we have over 16,000 individuals, male, female, adult felons on supervision, probation, parole. The majority of that population is doing okay. They're working, they're supporting their family, they're paying their bills. But a significant portion, 40, 50%, they are struggling with drug and alcohol addiction. And we've been seeing the usage of prescription opioids going down, and we've been seeing the use of heroin increasing. And we attribute that to public education, prescribing changes, and that drives people towards the street drugs, and I think that's leading to some of this wave of death that we're seeing with fentanyl and some of the other things that are cut into the opioids.
And then the demand for the street drugs increases the trafficking, and then you see that in your department, so it really is just a cycle.
It is.
All right. I want to thank all of you guys for being part of this discussion. I know y'all are very passionate, and the agencies are doing work to help stop this problem. Is there anything else that you guys want to add before we wrap things up?
Programs, education, and treatment can change people's lives. We see it every day in the Department of Correction, and the majority of this population can be successful.
Okay. All right. Well, thank you again so much for being there. Thank you to everybody who has been watching us online for this Finding Hope Live Town Hall event. For the last 2 hours, we've been talking with experts from all across the state. But as you can see, this issue is even bigger than that. Coming up on December 9th, we are going to continue to look at Idaho's opioid epidemic with an hour-long special in cooperation with our partners from Optum, Idaho. Starting at 6 p.m. December 9th, we will be looking back at stories we've already told, and we'll be talking with leaders who are taking up the fight with us. So keep an eye out for our Finding Hope, the Idaho Opioid Crisis Special on December 9th at 6 p.m. It will be airing on ABC stations all across the state of Idaho. So thank you again for joining.